Hi everyone, welcome back to our live fertility Q&A tonight. We are going to be speaking with Dr. Kenneth Gelman of IVFMD, and we are going to be answering your questions that you submitted. We also want to encourage you to type your questions in the chat. We are going to wait for Dr. Gelman to join under the IVFMD handle so that we can actually, I think he's trying to join through his personal, so maybe Dr. Gelman, you can switch to the IVFMD sign in, so sign out and sign in so everybody can see there as well. And I also just wanted to wish you guys a beautiful Wednesday. I hope that everyone is staying safe and feeling good. So if you have questions about your upcoming cycle, PCOS, endometriosis, acupuncture, what to do to, oh, there you go, I see you here, what to do to enhance your outcomes from any Medicaid cycle you're embarking on, then please feel free to let us know your concerns, and we will definitely get to them. So I see Dr. Gelman is in now. He just needs to ask to join the chat, and then I will go ahead and let him in. So another thing we are going to be having coming up next month is National Infertility Awareness Week, where we're going to be encouraging you to share your stories. So we do have several of our patients that are going to be speaking about their journeys and how that actually is, affecting them, or how they overcame their challenges. So if you are interested in speaking and inspiring others, please DM me at FL Complete Wellness and let me know. Let's see. So we're just waiting now to invite Dr. Gelman on. It'll just be a few moments. I think that he just needs to ask to be joined, and then we'll put him in. So Dr. Gelman, if you're watching, just a request to be on the live, and we'll go ahead and get started. Either way, if you'd like to join us, we are going to have some upcoming lives in April, and our goal is to actually make it easier for you to ask your questions, to talk about these issues with your friends, and also to encourage you and hope that you can definitely succeed in your journey. And we also know that it's very difficult to talk about fertility a lot of times, and we feel often that we're alone, and we're not. We have a lot of, actually there he is, okay. We definitely a lot of support here. So this is a free space for you to talk about your concerns.
Hello.
And there he is, hello, good evening.
How are you?
How are you? Thank you for coming in and answering all these questions we have. We actually have questions that were submitted in English and Spanish tonight. And so we're actually going to try to get to all those questions. Unfortunately, you don't speak Spanish, and I don't. Well, I do, but I'm not that fluent and to speak this, but Shirley, thank you very much. Shirley has translated these questions for us, so we have them, and we are going to get to those. So welcome everyone. And Dr. Gelman, if you could introduce yourself as well for those who don't know you.
How's everybody? I'm Dr. Kenneth Gelman, one of the doctors in IVFMD, one of the many now. I can't even remember how many we got now and how many offices, but we're spread out all over the state of Florida. I'm in the Cooper City office, and it's a pleasure to be here. It's always fun to be here every month and answer some great questions, actually.
They're actually new questions too. You've been doing this a while. I always learn something new, and I think it's really great to be able to jump in. So without further ado, we'd like to jump in. We are going to get to the Spanish questions first. So and I guess you can also replay this. Hopefully it will be saved also on our Instagram. So share this with somebody if you know someone who's struggling with fertility. These are really important pearls. Sometimes it takes years to learn all these things that we're actually going to talk about, and some people never actually address these issues. So if you do know someone who is struggling, please share this with them and invite them on right now. Okay, so the first question is how to know with basal temperature when you ovulate.
Well, that's the old way of doing things, I guess. Some people still like to do that. But the real thing with basal body temperature is it's useful in retrospect, which what that means is that once you detect a temperature elevation and you're checking, you've already ovulated, because your progesterone level starts to increase, means the egg is being released, and then your body temperature goes up because that's what progesterone does. It raises your body temperature. So, it might be 24 hours too late in a sense, but it's useful, I guess, to maybe have an idea where you ovulate. So possibly for the following month, you start using a urine-based ovulation kit, which will be much more accurate, and you'll be able to tell when you're ovulating, more closely, so that you can actually time your intercourse and things like that, and not, have an elevation of progesterone and, a temperature in retrospect and miss the ovulation window. So it's probably a good thing to do maybe the first month. And then once you kind of have an idea where that's occurring, or a month or two, then use an ovulation kit and, knock down, exactly when it's occurring.
And it's good to know after that. At least, if you have really irregular cycles, mention that, so maybe you'll have an idea of when the period might be.
You could do both, actually. You can actually see, when your temperature rises also, in addition to after checking the ovulation kit, hey, you definitely ovulated.
Right.
So that's a good sign. So we're timing things correctly. And if things aren't working out after several months, there may be something else going on there that needs to be checked out by specialists.
Definitely. So it's good to do. Yeah. Don't obsess.
Yeah, they're very simple things to do.
Right.
And cheap, so why not start that way? If you're just starting out, I think it's probably a good idea to do both.
And now they make a Bluetooth basal body temperature thermometer that Bluetooth to the app, so then you can check your app and you can see.
I know. I mean, it's amazing. Some of these apps. I had a lady the other day, and she, a lot of people have these menstrual calendar apps, or to actually know when their period's coming, because nowadays you ask somebody when their period is, and they look at their phone, and they may keep records on their phone, but the app says I'm getting my period 3 days from now, and a lot of times for some reason it's accurate, and I have no real idea why that is.
It's based off, I guess, if they're regular. If you're irregular,
yeah. I mean, pretty much. I guess if they're really regular, it can be fairly accurate. So it's pretty amazing, some of the technology.
And now, next question is: can low iron and vitamin D cause anovulation?
Not to my knowledge, but you'd want to maximize those things before you got pregnant. It may affect egg quality. I mean, there's some studies, yes, some people say yes, some people say no, about vitamin D and improving egg quality and things like that. So you want to make sure you maximize that by checking levels. It's very easy to do when you go to your doctor. I know we do that routinely on our pre-pregnancy panel. I believe it includes, your iron level, CBC, vitamin D, and then we'll maximize that. The nurse will call and say, listen, you need more vitamin D, and I'll suggest, whatever number of units and or an iron supplement. So it's important to maintain those things, because when you get pregnant, obviously iron is important, because, if you're low in iron, you're anemic. Well, gee, what happens when you get pregnant? It's only going to get lower and lower. It goes right into the baby. So, and you're not going to feel too good in pregnancy. So it's important to maximize all that.
It's super important. And there's even I think, there's research about trying to get that level up with vitamin D, but also for men too, right? For sperm quality.
Yeah. I mean, I think there's a lot about vitamin D we don't understand. I mean, there was some information even about COVID and vitamin D. Protecting against the virus and things like that. And I think there was actually a study I saw in JAMA, I think this week. It looked at high dose vitamin D in people who were already sick with the disease. It really didn't help, but it might help prevent, the virus from, getting into your cells in the first place,
Yeah. Yes.
so it may be important there.
So a lot of the fertility supplements we talk about are also good for the immune system. Well, I think we spoke about that before, and so that's kind of a good, two in one thing. And
Yeah.
the next question is: can a uterus with a 1.6 centimeter cleft affect the baby somehow?
Well, I don't know what that question really is referring to. I assume there was another question there about an isthmocoel, and I wonder if that was the same sort of question
Oh,
about a
right.
cleft, because I don't really know what the cleft is talking about. Are they talking about a septum? Maybe a septum in the uterus.
Septum, yeah.
1.6 centimeter, was it?
Oh, right. It says centimeter. Yes, 1.6 centimeter. Yeah.
Yeah, and that might be a septum in the uterus where the uterine cavity has an abnormality called a septum. It's a piece of tissue that actually divides the uterine cavity, not quite in two, but kind of delves down and gives it sort of a deep cleft look to it. And septum, if it's a septum of 1.6 centimeters, that's pretty borderline. I mean, that probably should be taken care of surgically with an expert surgeon who's done cases like that, where they can go in hysteroscopically and repair the septum down to at least maybe a half a centimeter or so that it's not causing potentially implantation failure, because septums are typically not vascularized enough so that if embryos are implanted in that area, you can miscarry. I mean, it's not guaranteed you're going to have a miscarriage, but there's certainly a higher incidence of it with something like that. So those types of abnormalities should be surgically corrected, especially if this person has had miscarriages before.
And with
That would be looked for.
endocrinologist or with a surgeon?
Yeah.
Or?
Yeah, the people who would look for, well, an alert gynecologist obviously would find it on an ultrasound, or a reproductive specialist would definitely see it, because they would do an ultrasound and be suspicious, because when you do an ultrasound and there's a septum or a split in the cavity, as you're scanning through the uterus, you see one endometrium going this way and another one going down this way, and you say, And then if you have a 3D ultrasound, you could do a 3D ultrasound right then and there and get an idea potentially, or an SIS study, which is an infusion of salt water in the uterus, and that you'll be able to see those abnormalities, and then pick it up and decide from there. Obviously, if it's amenable to surgery, or surgically, if it needs surgery in the first place, that kind of thing. So
that's important to get evaluated then beforehand for the
yeah, because I assume that's the question. It sounds like it's a septum from 1.5 centimeters, because a 1.5 centimeters wouldn't be an isthmocoel. That's way too big for that.
Yeah. Well, yes, that might be a different person asking about this.
Yeah. Sounds more like septum. Yeah.
Okay. Yes. Cleft, or that's what the phrase is. Yeah. And so there's another question: is it normal to transfer the 3-day embryos without doing a genetic study? I guess.
Yeah. We don't. Nobody does that anymore. I mean, PGT on day 3 embryos is notoriously not accurate at all. I mean, the embryos at that point, aren't mature in a sense, and checking the chromosomes at that point would be very misleading. And that's why we do day 5, genetic studies, because the embryo is much more developed at that point, and that's the embryo that would implant in your uterus normally. So we sort of mimic that whole system in the culture, and we do biopsies on day 5, where you have much more of an accuracy of 90. They say 98%, 95 to 98% accuracy. But day 3s would not be accurate at all. I mean, some people still transfer on day 3, and some people obviously do get pregnant, but most people now are going to day 5.
And the cell that they're using to test, is that from the placental cell or like how?
Yeah, that's the PGT testing is the cells from the developing placenta, the outer cell mass, trophoblast it's called. And they don't go in and actually biopsy the inner cell mass, which is the actual developing embryo. They don't go in and do that. They cells, and that's one of the problems with this procedure is that it could be inaccurate in maybe 5% of cases, 3% of cases, because there's something called mosaicism that it may or may not detect. So as a double check for somebody who's had PGT, maybe over 38, 39, 40, probably should, when they go to their gynecologist, should have a panorama or harmony test, which is the DNA, fetal DNA, that actually circulates maternally by 12 weeks. So you'll have a much better idea whether we're correct or not. And occasionally and rarely, we find that a PGT embryo that's, quote, normal that we implanted is not normal. So it can be detected at that point, but it's rare. I think we've had 1 or 2 cases over the years. It really doesn't happen. So the PGT has been pretty reliable.
Okay.
But they're coming out with new things like cell-free DNA, where in the media, in the discarded media, so to speak, is DNA that could be analyzed. And there's been some preliminary studies. I saw something about that it's about 95% accurate too. But it's not out there yet. It's not approved for use.
Okay. Yeah. And that's why questions are so important because things change, right?
Yeah.
And years ago,
Yeah.
that,
And that's why I think some people, rightly so, maybe, because we never transfer an abnormal embryo by PGT. And, some of these embryos really aren't that abnormal by the biopsies that we get. Like sometimes they may have, maybe they're missing 1 chromosome or they have 1 extra chromosome, as opposed to multiple chromosomal errors, which, those are probably really abnormal. But some of these with maybe 1 chromosomal error, you kind of wonder, is it really an abnormal embryo or not? And, there are some people who would not, discard those embryos. They would maybe keep them for later testing, like in the cell-free DNA system. If they retest them, are they really normal? So that might be food for thought for some people out there.
okay. And so as far as, okay, this is a question about an in vitro treatment. Forgetting to take birth control pills once a day, can it affect? So I think they're talking about the pre stage where you're taking birth control for a few weeks.
Yeah.
If you forget to take it one day, what do you usually recommend?
Well, depends on how far in advance of their stopping it. But for the most part, it probably isn't going to matter very much. We can probably double up.
Up the next day or
yeah, we could probably get away with it. So it's probably not a big deal. Although if people miss a day, it's possible they could ovulate. So if they start bleeding or have some irregular bleeding, something like that on these pills, they should get checked. Because sometimes the progesterone rises or something, and then, we have to start over. So, it's very important to take those birth control pills exactly the same time every day. Not only, in this situation, but even in, people who are using it for contraception, for better cycle control. So in that situation, it might result in potentially an ovulation. So, but sometimes we try to get away with it, and we'll see how it goes after a couple of days. If things aren't, stable, then they should get checked, because sometimes you may have to start over.
There are times when you don't recommend birth control for patients doing IVF? Or
A lot. We're doing that a lot, and I noticed that my colleagues are doing it too, because I started estrogen priming a lot of people who have, maybe diminished ovarian reserve, or they've had a poor cycle, and maybe I don't want to suppress them too much. I want to try to get as many follicles to develop, in the subsequent cycle, and not, put a clamp on the ovary necessarily. Because sometimes we have to keep people on birth control pills in order to program them. We do things in batches in our office. So I tend to not like to keep people on birth control pills very long if they're on it, or I'll use a lot of estrogen priming before we start the stimulation, because that seems to give you a nice synchronized follicle pool for the stimulation purposes, as well as not over suppressing the ovum, which is, a good thing. You don't want that, because, I think that more embryos is better than less.
Yes, so there could be that risk of over-suppression, I guess. So,
Yeah. No question.
we do have a question in the chat. Is there a certain age IUI is no longer recommended? I'm 41 with PCOS, considering IVF, but wondering if IUI is recommended at this age.
Well, I wouldn't do it. I would go to IVF. I think the recommendation is now really came out a while ago that at age 40 or higher, there's no question IVF should be offered first. And there's even some question. There was that debate in the Fertility journal a couple of months ago. Should IVF be offered first, period? Because it's so effective in a lot of cases. But certainly at age 40, if you have the choice, or you have the ability to go to IVF and you're willing to do that, or, unless there's some reason you don't want to do IVF, or, whatever it may be, I would go to IVF. I think that's much more effective. You can check your egg quality, and, you're actually doing an analysis on your eggs, really.
And the success rate is higher. Obviously.
It's much higher, and even, IUI at best with, not at that age, younger, but, at best there's maybe 20-ish%, if that. The national average is lower, actually, with IUI, and that's with perfect tubes, perfect ovulation, perfect eggs, that kind of thing. It does get better over time, but it has no equivalency to IVF. It's not even close.
And I guess you consider, if you have PCOS, you might actually have a lot of follicles. And
well, that's true. So, that person, even at 41, they might, their AMH may be high. It's interesting, at that age, you might see an AMH of 2 or 3, which, for a normal person, an AMH of 3 at 41 is high. But for PCOS, that's low. So that would already suggest, she's got a diminishing ovarian reserve, but it's still high for that age. But, that person, still would have egg quality problems at 41, even though they may have a lot of eggs, or more than the average 41. They're still, the mature eggs we're going to get are still going to be potentially problematic. At 40, 70%, or probably at 41, a little more, of those eggs may not be normal chromosomally, statistically. So, we have to, make sure they're aware of that.
Yeah.
So, and then when you're thinking about IUI, well, 70% of the time you ovulate, so it's no wonder it doesn't work at 41. Well, but listen, I'm never going to say never. I'm the first guy to say that.
Maybe you try one and you see how it goes.
Yeah, there's no harm in trying it. Of course not, but you got to be, I wouldn't do 3 or 4 of them and then, kick yourself saying you can't afford IVF, because you could have put that money towards a more effective procedure.
And I guess you can think about how many children do you want. So if you were to get pregnant, it's putting you at 43 probably to try again,
That's correct, because if they get, that's exactly right, because, at 41, your egg quality is, is still doable in a sense. You may want to try IVF for a couple of retrievals, and, maybe you'll get 1 or 2 embryos out of that. And, you'll transfer one, you'll have another one for next year, because you're right, exactly right. If you got pregnant and let's say you ended up with a C-section, and or breastfeeding, that's going to delay till 43. That you could forget the second one.
Yeah, definitely. So I have another question about IUIs. While we're on the subject, someone just typed in, does back-to-back IUIs increase chances of pregnancy?
Well, I always think if you're going to do IUIs, do them back to back, and it's also the same thing kind of concept in IVF, and if you look at statistics of IVF IUI, they get better cycle as you go into 2, 3, 4 cycles. The success rate goes up, and I always notice that. And that's because I think, and nobody's really given me an explanation in terms of why that is, but I think the use of the drug, because typically people use, drugs, in IUIs will use, Femara or clomiphene or whatever it may be, and it tends to make the ovaries much more efficient,
Mm-hmm.
you know. And I always use this analogy. All the patients tease me because I say, you're not a car engine, but there's a lot of things in life that are analogous to what we do. You prime a car engine, you send your car into the mechanic, and they oil it and they grease it and they do all this. They change the belts, and it runs better.
Unless you have,
It's the same sort of thing. We're just kind of priming the engine, with these fertility drugs and things like that. So the ovulations improve, and maybe success rates do go up, but still IUI success rate, like I said before, doesn't approach IVF, and maybe gets up to 30% after 3 or 4 cycles. And we do get pregnancies, and I'm not saying I don't do them. We do, but I want people to be very aware of age, age-related decline in fertility, egg quality. Are you doing the right thing? The finances, a lot of stuff isn't covered. Are you doing the right thing? Are you being, the most cost-effective you can be in trying to get this done quickly?
What gets me is when the insurance companies say you have to do 3 IUIs before you
Yeah. That drives me crazy too. But there is some sometimes there's some very good medical directors. I actually have a very good relationship with a fellow. I think he's in Las Vegas. I can't remember his name. He's from United. He's a very good guy, very smart guy. I think he's an RE, and he's very good. We call him if we have any issues, and he takes care of these problems. And he tells us exactly what we need to do to get things covered. I mean, it's great to have a guy like that. So when you get to the medical directors, but a lot of times you don't, because it's usually maybe a lower level person handling this, who just doesn't really understand the medical aspects of things and doesn't look at that and just says, listen, they didn't do 3 IOIs. That's it. You got to do 3 IOIs. And it really kind of drives us crazy.
Yeah. Yeah, it's not right for everyone, And then there's another question: does sperm decondensation affect conception?
Yeah, I think it does. I mean, I think those are that's a good question. I think,
Yeah.
Males are difficult. They're difficult to understand sometimes. But if somebody has an abnormal decondensation test or sperm chromatin structure, I say that means the sperm is disrupted from whatever it may be, some kind of toxin. Maybe they're exposed to pesticides, or they're inhaling things. They're working with chemicals, and or maybe excessive heat exposure, or they're heavy marijuana smokers and or cigarettes or drinking. These are the things that we know affect sperm function. So it may be no wonder that this person may be getting pregnant, but they're miscarrying. And it might be due to the male factor. So one of the things that has to be looked for in a miscarriage workup is abnormal sperm decondensation, abnormal sperm chromatin structure assay, things like that. That has to be looked for, because that's a potential area of concern. And those men, maybe they have a varicocele, maybe they have some kind of thing that needs surgery. Maybe we have to remove the offending toxin. We got to tell them to stop smoking and drinking. We got to ruin the party a little bit. Put them on heavy dose vitamins and cocktails and things like that, and maybe repeat the test in 6 weeks or 3 months. they can maybe that's the right thing to do, or maybe they had the flu, maybe they had a high fever,
Mhm.
something like that. So that could definitely be an issue. So
Can you,
that's got to be looked at.
can you explain a little bit what the sperm decondensation is, or for those who don't know or not
Well,
familiar?
it's a test that they look at sperm function. It takes a semen analysis to another step. It's like putting the sperm into boot camp
Hmm.
and seeing what the sperm does, under situations like, for example, they use, I think, a frog egg membrane setup to look at how the rate of a sperm cell compared to controls, how long it takes the sperm to decondense, which means fuse its egg membranes, fuse its membranes so that it can actually fertilize. Because sperm has to go through a decondensation process, decondense the DNA, and fuse the membranes in order to fertilize. So they're able to measure that as compared to controls. And so you get a percentage like, it does it at 60% instead of over 80%.
And the norm is around.
80, I think, 80.
Okay.
And then they also look at sperm disruption, sperm chromatin structure assay, which looks at, if the sperm is beat up. You can look at, I think it's stained sperm, and you can actually see DNA in the media, so to speak, and the sperm's heads are disrupted. So, there's special ways to look at that and to detect whether that sperm looks normal and is functioning normally. Basically, that's what it is. So at least you have an idea, but maybe you can repair it. That's my point, is maybe it can get better, because sperm is made in 3-month intervals.
Right.
Sperm is, is constantly being reproduced. So,
Okay.
it's a little bit of a bummer, because the sperm and the men are doing that, and then women's eggs are going bye-bye every day, completely. It's not really fair, is it?
Is it recommended right off the bat to do that test? Because I mean, I don't know if that's really
Well, I tend to do, it's a good test to do right away. If somebody's trying for a year
right.
and there's unexplained infertility, maybe you should do that test.
Hmm. And that,
That might be a good test to do, instead of the standard, well, HSG and, AMH and,
right.
all that stuff, maybe we should look at the men a little bit too. And that test should be done, especially if somebody's been trying for a year and a half, whatever it may be. And there's no explanation. Well, that test should be looked at.
Okay. And that usually it's going to be done like on a initial evaluation.
Yeah. So we'll be sitting there with the couple, or on telemedicine these days, and we're going to say, listen, we're going to get this test done, and it's an extra charge. Some guys don't want to do that, but it's helpful. You can tell the guy, listen, here's the issue here. Here's what we think may be going on. Let's repeat it 3 months. Let's put you on these vitamins. Let's stop all the marijuana, and or alcohol, and let's improve things and see what it does. Let's put you on a Mediterranean diet, an exercise program, and acupuncture, and all kinds of things. Because I know I've sent guys to you over the years, and acupuncture has done some amazing things for them.
Well, yeah.
And I think it's a lot of it's stress reduction and blood flow. I think it's the same thing with women.
Mm-hmm. We had a patient who went completely 360, or he was a cigar smoker and a drinker, and he actually lost 20 pounds. He just made. He said, and he actually is now like fitness person. I mean, he, completely changed. And they actually got. They think they have 2 kids now. So, but I mean, definitely, it's that it can affect the sperm count, and it actually can reverse this damage, like you're saying, just in 70 to 90 days sometimes. But it's good.
But if things are really, really poor, I mean, there's some people that have real problems in there, that isn't due to some kind of toxin or fever or whatever it may be. And then we obviously have urologists. We have some great urologists in town, Dr. Ramasamy being one, and he'll see a lot of these people. He'll figure out what it might be, and he'll help them too. So there are guys with real organic problems too, who just have sperm production problems.
We are getting a few COVID vaccines.
Yeah, a lot of them.
So I know I just saw one here, and we also have one that was submitted earlier. So the one that was submitted earlier was, is COVID vaccine recommended before IVF? Any future effects or areas of concern? And then this question.
These are huge questions these days, and nobody's got these answers. Nobody, um, if you think about it, I mean, there are going to be people, maybe who are just, are offered the vaccine, and obviously you should get it. And then, whether you should do IVF, right away, I don't think is the right thing to do. I think some of the recommendations are to wait, at least a month, maybe 2 months to actually do your transfer at least. Because, when you take a vaccine, like any vaccine, you're getting what's called controlled inflammation. Your body is reacting in a way, and you're getting certain inflammation produced that's, in a controlled fashion as opposed to uncontrolled inflammation, which is, pathological, like in disease, that's uncontrolled inflammation. So, whether that controlled inflammation can influence, pregnancy or not, I don't think, we don't know. I mean, I don't know for sure, whether that will or not, but the recommendations are not to transfer, or not to take the vaccine within at least maybe 2 months before getting pregnant, or a month, at least a month, a minimum of a month,
The second dose for the.
Yeah, the full vaccine.
Okay. Because I know that ASRM they just released new guidelines. I think the other day I got an email from them saying, that this is what they're still reiterating. I guess that it is safe during pregnancy, safe to do prior to, or I guess.
Yeah. I mean, I think they're saying that, but we're also rethinking it, and thinking for people who are spending X number of dollars on IVF. We want them to be successful, and we don't want to have any second guessing. Also, did the vaccine have anything to do with this? It's so new, and I had my transfer a week after. Who knows? I mean, I think I'd wait at least a month, let the controlled inflammation kind of die down. Some people are delaying the vaccine who are getting pregnant, like now, into the second trimester. When things are kind of progressed through the first trimester, they're waiting to the second trimester to get their vaccine. I guess that's probably a fairly smart thing to do.
Yeah. Like there was a case where a baby was born to someone who was vaccinated in the third trimester, I believe, who has antibodies.
Correct. Yes, that's true.
First case.
So there you go. So that may be a good thing.
Yeah. So we'll learn more as we go on. But for now, your advice is to go ahead and get, if you're going to do the vaccine, to get it, done like in plenty of time beforehand.
Yeah, try to, if you can. I mean, that's going to maybe a challenge, for some people, because, they may just all of a sudden get it offered to them. And obviously everybody wants to get it. It's a smart thing to do right now. But yeah, it's true. It's a little bit of a problem.
And so I hope that answered the question, because I know there was, yes, there was about regarding an IUI, but this would apply for IUI or IVF in general. And also I would think, that they are recommending Tylenol, after you get the second dose or something, or, just to kind of mitigate any fever, that sort of thing. Well, there is a question about acetaminophen that we got, and, I'm trying to leave them in here because there was one question that said, will acetaminophen accidentally kill a fertilized egg a few days after ovulation? But I don't think that is the issue with acetaminophen. It's more of could it like suppress ovulation somehow, or interfere with
not Tylenol. Drugs like Advil will.
Okay.
So we try to make sure people don't take Advil around ovulation time, because it's what's a prostaglandin process, and those drugs will interfere with it. So Tylenol would be acceptable.
Okay, so that will answer. So yeah, no effect. That was a question here about no effect on a follicle per se. And we have another question about recommendation of vitamins prior to transfer. to improve receptivity, what can I do?
Oh boy. You know, the issue of receptivity is such a complicated issue. I mean, you know, I think, you know, there's so many things, not only vitamins, you know, obviously, you know, as doctors, we have to do our due diligence and make sure you're as receptive as possible in your endometrium. I mean, you know, obviously if you're doing a frozen transfer, for example, we got to make sure, you know, obviously your lining's thick enough, and that you're receptive, or we think you're receptive. I mean, for those of us that do ERA testing, you know, that might be one avenue. You know, immunologic testing also to make sure, you know, we don't have any immunologic concerns about, you know, implantation. You know, there's all those areas, obviously an SIS study to make sure there's no septum like we talked about before, you know. So it's a lot of things, you know, but I think, you know, the question here is maybe focused more on, you know, what vitamins do we usually recommend before you transfer somebody? Well, we maximize their vitamin D, obviously. Mm-hmm. We want to, you know, make sure they're getting a good prenatal vitamin and, you know, those kinds of things, and good diet. I mean, obviously health. How many times have we discussed that here?
Oh, a lot, yes.
You know, and those are the things, you know, I think we should really focus on.
Yes.
You know, that kind of aspect. It's not so much the vitamins you're taking. It's really about preparing the whole soup, you know. If we're a cook, I'm using all these analogies today. So if, you know, if you're a cook, you want to prepare the best possible soup you can possibly make to serve to your fancy clients, you know. So we got to make sure all the ingredients are in there and everything's cooked correctly. So it's not just the vitamins, it's everything that goes into it.
And we have, you know, similar saying in Chinese medicine where if you want to have good fertile soil, then we want to, you know, make sure that there's no rocks in there. And
well, basically, yeah, you don't want any rocks in your soup, right?
Yeah, exactly.
You don't want to.
That would taste terrible.
No, I don't think I'd want that. You know, nobody would come back to my restaurant, you know?
Yeah. That would be horrible. Yeah. So we want to get really a nice, you know, fluffy, cloudy lining. So
yeah.
Look at it like that. You know, sometimes we have patients that come in that say you know, that their cycles are very cloudy or dark or painful or brown or all these different things that are kind of really not, you know, optimal in Chinese medicine prior to getting pregnant. So we try to work on that, and we could, you know, see that as a report card and say, look, there are things we can do here. We can do some acupuncture, myo-abdominal therapy. We can work on stress. We can work on nutrient absorption.
Yeah, there you go.
Look on gut health is important. All is good things. We need time to do it. So again, if we have like a few months to do this, that's perfect. If you are having those kinds of cycles, and it's kind of nice because people can actually see the results. They can see month by month that their cycles are improving. And we usually can see that translating into, okay, look, I've got my linings a little bit, you know, thicker sometimes, or maybe they are getting pregnant a little easier. So they actually have Doppler studies they've done in other clinics where they can see the blood flow improving to the uterus. So that is helpful. I don't know if anyone does those anymore, but that would be awesome to see that.
No, I don't do those anymore.
Yeah, no. It's just back in the day, but I think it's great to, you have ultrasound, so we always ask that question. Like,
well, that kind of leads into one of your points that you were saying about bleeding and irregular bleeding and things like that. Somebody asked about an isthmal seal, which is a good question because I don't think we've ever had that before, and that's a, you know, a defect, a C-section scar defect that you know, where the C-section scar doesn't heal properly, and it, you know, it communicates with the endometrium, and you know, there's blood in there, and you know, since there's endometrium in that little defect, which is like a triangular defect, you know, it can cause spotting and irregular bleeding and things like that. That, you know, these people are always misdiagnosed, I think, a lot of times because, you know, they're always maybe seen by non-specialists, maybe, and they, you know, get, you know, they're told it's nothing, it's going to go away, or, you know, and maybe they're put on birth control pills for a while, which will maybe stop the bleeding a little bit because it's, you know, the endometrium and the defect that's causing the bleeding. And then they stop the birth control pills, it comes right back. And then, there's a good question there, because somebody asked about infertility and these kinds of things. And yeah, I mean, that's an important thing, because that can cause, a problem with blastocyst implantation, because, you're getting this abnormal blood inside the endometrium there that shouldn't be there. So, it's a real thing, and it definitely happens. And, you see it on ultrasounds on occasion. And then, that has to be fixed surgically, in somebody that's trying to get pregnant or is miscarried maybe from that. You would think that it wouldn't be a problem, but it is, especially if it's large.
You can see that in
Yeah.
S, or what type of
Well, you either do an SIS, or you sometimes see it, get an idea on an ultrasound that's there, because you see a little triangular deep defect. It looks like a little triangle.
Oh, okay.
And I mean, you have to know kind of what it is. I mean, I think some people maybe could confuse it with what's called a Nabothean cyst, which is a mucus cyst. It also looks black, and so does the isthmocele. And it's a mucus retention cyst inside the cervix, kind of near where an isthmocele might be. But some people might confuse that. But, it's there, and it can cause problems with some individuals. But people obviously had C-sections or multiple C-sections, and, things like that. They tend to possibly get that. I mean, they say the incidence might be 20 or 30%.
We have a question that came up here. Thank you for Blueberry. Thank you for that very sweet comment that you just wrote. And April Flowers, we really appreciate you guys. And we love doing these Q&As, because
This is great.
I love
these are a lot of fun.
And we always learn. I always learn more things too every time. So at Blueberry, if you want to share your story also next month, we're going to do a little, we talked about patient stories for Fertility and Fertility Awareness Week. So
Right.
like I said earlier in this start of the show, that if you guys want to share your story, please do. It will help others. You never know who needs to hear it. And we did share Rosemary's story last week with Dr. Wood. I thought that we actually got a lot of feedback on that, because sometimes going through losses, going through IVF, going through IUI, this is so hard, not easy. And we definitely appreciate you being able to help someone else too. So we do have a question about how do you avoid aggravating endometriosis for IVF? Does the estrogen from IVF act like pouring gas on a fire?
Yeah, good question. That's a problem in a sense, but it depends on how bad the endometriosis is, obviously. But yes, and estrogen will stimulate it. So when you are going through your stimulation, yeah, we're stimulating endometriosis. There's no question about it. We're flaring it up. That's why anybody with endometriosis should not get a fresh transfer. I mean, that's pretty much, solid these days. So that really shouldn't be done for that reason, because, endometriosis is an autoimmune disorder, really. And your autoimmune system, starts to aggravate and act up. So that's, pathological inflammation as opposed to controlled inflammation, like I spoke about before. So, after the egg retrieval, obviously, then patient will go back on birth control pills, and we will have time now to cool off that endometriosis, maybe with a progesterone-only pill and or Depo-Lupron for a couple of months before transfer. So just for that reason, just for exactly that reason that person asked. And to make sure, whatever markers we can follow, maybe a CA-125, is down, the patient's not having any pain. Some people have gone through surgery even before a frozen transfer with the idea maybe we'll improve things, but that's not really shown to be of benefit, but some people have done it and have done well. And, you know, maybe Depo-Lupron instead of surgery for 2 to 3 months before a transfer. That might be a very good thing for that person to do.
Now that frozen transfers are more the norm than fractions.
Yeah, you know, obviously it delays things. People are, you know, anxious to get pregnant. We understand that, but you know, we want to have a good outcome. We don't want to have recurrent miscarriages or implantation failure. And you know, I think in this person with bad endometriosis, particularly, I think that might be a way to go, to give them at least 2 months, maybe of Lupron, and then plan the transfer that way.
Oh, very good, very helpful. And we do have a question: pregnancy at 43 with frozen embryos, risk and difference with a young woman.
Well, I assume that person has had, you know, frozen embryos from a previous IVF years ago. And at 43, you know, as long as you're a healthy person, you know, it should be fine. I mean, I think, you know, some of those people, depending on any health concerns they may or may not have, you know, we'll have them see, you know, perinatal specialists for a consultation beforehand, because the risks, you know, in pregnancy will be, you know, higher than a younger woman, particularly things like gestational diabetes, preeclampsia and hypertension, you know, things like that will be much higher incidence at somebody at 43. But if the embryo was produced when they were, you know, 32 or, you know, whatever it is, you know, that pregnancy, that should be a healthy pregnancy theoretically. It's just the pregnancy itself may be complicated because you're older and more prone to developing complications.
Definitely. I think that I mean, we do have patients that are even older than 45 who are pregnant, and they're using, you know, frozen or their donor. Or...
Yeah, exactly right. Because you know, we have patients who were using egg donors, and I remember a couple of years ago, a few years ago now, I transferred a woman, 49, almost 50, never pregnant, and she has twins.
Oh, wow. I'm a life change.
Yeah. And she brought her twins in. Wow. Unbelievable. Yeah. Very happy
Awesome.
people. Yeah.
Very cool. So we also have a question here. Best days to baby dance around ovulation to conceive.
Yeah, the baby dance. Well, you know, again, that goes back to, you know, our first discussion of the night, really, where we talked about ovulation kits and, you know, checking your temperature. You know, once you know where you're ovulating and you use an ovulation kit, you know, theoretically, when it turns really dark and the kit says yes, you're beginning to ovulate, you have theoretically 36 hours in that window. Somewhere in that window is your ovulation. Now, not exactly where, you know, everybody's probably a little bit different, but it's within 24 to 36 hours. So I usually recommend people, you know, have relations, you know, 3 times over that 36-hour period, but you spread it out maybe over 12 hours. So 3 times over that period. So that goes back to what we talked about earlier. So if you know you're ovulating on day 14 and you confirmed it with your thermometer that yes, my temperature goes up on day 16 or 15, you know, whatever it may be, then, you know, you're able to time relations better for the subsequent months, and then your husband can, you know, abstain for 3 or 4 days before this occurs, so that, you know, theoretically you have maximum energetic sperm at that time. So, you know, that'll give you a little bit of guidance there on how to do that.
And the sperm can survive up to 6 days, is it, in the reproductive tract?
Yeah, it could. It could.
They're healthy. Good.
It could. I mean, yeah, it's been detected up to a week later sometimes.
We actually did have a patient one year. He was 6 days prior to ovulation. She got yeah. So I guess that was the last time they had tried, and then he went out of town and missed the window. And it's like, what? no, we didn't. It can
Hey,
happen. Oh, those,
hey, there's some guys out there with super sperm, I'll tell
there
you.
you go.
Uh,
So we have a few more questions, and we are
we got a
almost to,
lot of questions here.
I
We,
know.
we get a lot of them popping up
It's
for you. I'm telling you, I wish I could answer all of them.
when we get to the end, we're like, oh, we want to answer everybody. And I know that someone posted their question on our Instagram page, and I cannot flip to it right now. And I'm so sorry about that. And if you're listening and you're the one who did that, please, you can, I will try to answer you after this because I'll get to it. But if you can repost that question, if you're listening, then that would be great because it was a concerning losses. So,
There it is. Somebody just said they got super sperm. They heard me.
oh, really?
Yeah.
Okay, well, awesome. So we have, okay, let's see if we can get to, we have a few more questions and then we will be wrapping it up tonight. So we have, uh, okay, I'm sorry, I'm trying to go back and see here. Okay, what does the EIP portion of an ERA test for?
Yeah, that's part of that's not part of the ERA test. I add that. I mean, a lot of the docs add that. I mean, it's called endometrium immune profile. It looks at, you know, cytokines or chemicals from the immune system that may be present in the endometrium under the influence of all that progesterone and things like that, or whether we're doing a good job and, you know, suppressing any of that, and whether there's, you know, for example, somebody with endometriosis, do they have a lot of stuff, cytokines still elevated that we can actually detect in the endometrium when we do a mock or fake frozen embryo transfer protocol, so that we know that, hey, maybe there's some implantation issues that we should address here because these chemicals are elevated and maybe that person needs intralipids. And I think it's a pretty accurate test, and more so than blood levels of NK activity, things like that, which can be non-specifically elevated sometimes. But I think this test is pretty darn accurate from what I've gleaned over the years of doing it. Some people need an endometrial scratch procedure based on these results, which creates a controlled inflammation inside the uterine lining to create the proper, what's called cytokines for implantation. So, you know, it's a useful test, I think, especially in somebody who, you know, has failed multiple transfers, has immunologic issues where we know potentially we have to address that. You know, maybe somebody that has a single embryo only, we want to try to really maximize everything before we do even that single transfer.
Okay, so you're saying you can actually see the natural killer cells?
Well, the products of, you know, the products of those kinds of things. So that's really what it is. And since we're doing an ERA biopsy for progesterone effect, we just grab an extra sample and send it to the immunology people.
Okay, that's interesting. So you would still recommend though the blood test though for the
Yeah, I mean, you know, the either or sometimes can be elevated. You know, I think the endometrium one is more accurate, but I think either one can be helpful, and sometimes you have to make a judgment call too, because there are some people who maybe, you know, for example, they may have had miscarriages, or, you know, they have a single embryo. Do we want to really kind of pull out all the stops and give them empiric intralipids and or Lovenox or whatever it may be for, you know, implantation purposes, because, you know, we're trying everything, and even though we don't have specific answers on whether things are really abnormal or not, we still may want to do that.
Okay, very good. And so I skipped a question here, but it says you mentioned you wouldn't put someone with DOR on birth control before IVF. What about a 29-year-old with 0.8 AMH?
Good question. Yeah, I mean, that's probably a person I would not put on birth control pills. I mean, if that's a real AMH, and we've talked about this hundreds of times on this talk sessions we've had, you know, make sure your AMH is a real one, and because certain labs are notoriously inaccurate. So you got to verify with your doctor or come to us, and we'll tell you whether it's real or not. We'll do a natural follicle count. We'll take a look at your ovaries. We'll give you an idea what's going on. And if that's a real AMH, which happens, does happen, that's somebody that should not get birth control pills before IVF.
Yeah, too suppressed. Yes,
I wouldn't suppress her.
Okay, great. And last question. I think we are on our last question here. Do ovarian cysts affect egg health?
Well, depends on the cyst. I mean, no. Unless it's an endometrioma, maybe. I mean, nobody, endometriomas or endometrial cysts, endometriosis, cysts inside the ovary, and, that might affect egg quality, or probably does to a certain extent. That type of cyst will. I mean, there's other types of cysts in the ovaries. There's a lot of types. Like a follicular cyst, which is a plain, fluid-filled cyst filled with, water, basically, is nothing. That's not going to affect anything. Corpus luteum cyst is a physiologic cyst where the person's ovulated from. So there's various types of cysts. And I would specifically say that, endometriosis of the ovary and endometrioma is probably the only type that might affect egg quality to a certain extent in some people.
Okay, guys. Wow, we covered a lot.
We had a lot of questions.
Yeah, that was awesome. So thank you so much, Dr. Gelman. If
My pleasure.
they'd like to find you, they can go to IVFMD.com and do a virtual consult or in person, right?
Yeah, absolutely.
You can.
Absolutely.
And we recommend him highly. Our patients love Dr. Gelman. He has gotten really amazing results. And then if you'd like to see me, I'm in.
She's the greatest too. You got to go see Farah.
Yeah,
Get your acupuncture, boy. You'll all feel great. Everybody comes back and says, I feel so great after that.
Awesome. I'm glad. I'm really. I'm glad we're the highlight of the week sometimes, even when.
By the way, was that you doing yoga?
Yeah.
Is that you doing the headstand?
I did an elbow stand.
My God. Go
Go
on her website and look at her doing a headstand there.
No. Well, during lunch.
You're in pretty good shape there, Shara.
It's been a while, but I. And
Huh?
I'm actually going to be teaching some fertility yoga coming up, like a few.
Oh, that's great.
Yeah.
We should do that. That's a great idea.
Hey, guys, just give us a little heart if you'd like to see Dr. Gelman do some fertility yoga.
Oh, not me. You.
Yeah, it actually is great. If you guys ever get stressed, just kind of stand on your head, or not, not to stand on your head completely, but
yeah.
Inversions
yoga. We highly recommend yoga. We really do. I think it'd be great for you guys. Anybody out there, it's a great way to reduce stress. You'll feel terrific. You won't have any back pain, nothing.
Yeah, no, it's great. And so we'll keep you posted on that. But thank you, everyone. You can go to Florida Complete Wellness if you want to learn more about the treatments we have. And we'll be back. We're taking a week off for spring break. And we'll be back in April, early April. And we'll continue our Q&A. So thank you guys very much and have a great night. Thank you, Dr. Gelman.
Good night, everybody.
Good night.